And joining us now on the debate for the full hour, Eleanor Kaplan, Ontario Minister of Health from 1987 to 1990. Dr. Anne Doig, past president of the Canadian Medical Association. Ted Ball, health policy analyst and chief of staff to former health minister Larry Grossman. Natalie Mehra, director of the Ontario Health Coalition. And Sholem Globerman, founder and president of the Patients Association of Canada. Good to have everybody here around our table for what we hope will be an enlightening discussion about healthcare for the next hour. And I want to start by quoting somebody you all know. This is Andre Picard from the Globe and Mail from last year, who wrote, "Patient-centered care and family-centered care are the buzz terms du jour, but there is a lot more talk than innovative action. Offering up convenient, timely care, making it easy to navigate the system, actually communicating with patients, and treating them with respect do not seem like radical ideas, but sadly, they are not the norm. Far from it. There are too many vested interests, too many silos, and always too little time to listen. Health professionals want to deliver high-quality, compassionate care, and despite the barriers often do, but they are too beholden to systems and constrained by traditional ways of doing things to put patients and their families first." Okay, that's what we're going to talk about tonight, and I guess we can let the cat out of the bag now if it isn't already out of the bag. Yes, Eleanor Kaplan, you were the former Ontario Health Minister who on a scale of 1 to 10 said we're doing 1 when it comes to putting the patient at the center of everything we do. Why just a 1?
Well, first of all, we don't have a system. And government's role is just to pay, and we have silos everywhere. And what I've said is that if we only had one policy change that we could make, if that change was to put the patient and person's interests first, ahead of provider interests, then you would have a very transformed and development of a real system.
You say the provider's interests are first, so
yeah, well, for example, our hospitals, they are providing excellent care, many of them are not. However, they're keeping bankers' hours. You try and get anything done after 3 o'clock in the afternoon or on a weekend. That's when people are available. You have to take a day off work if you want to have a doctor's appointment or see somebody. Now, we're starting now to get the requirements from government for 24/7 and family health teams and people working together. That's all new.
Anne Doig, in terms of putting the patient first, on a scale of 1 to 10, she says 1. What do you say?
I'm not sure I'd give us a 1, but I think Eleanor's absolutely right. We're not in the top third. We're probably not even in the middle third. Patient-centered care on an individual contact basis, patients are very happy with the contacts, the individual care they get, both from their physicians and from other care providers. But when you put the patient into a very complex system, Eleanor is absolutely right. There is a lack of patient-centeredness, and that is indeed the first principle that's underlying the CMA's proposal for transforming healthcare.
And we should remind everybody, you're here representing the docs.
That's what I'm here for.
What do you say, Ted?
Well, I think Eleanor's right. I think 1 is about, if you're taking a look at it from the design of system structures and processes, we have never put much emphasis on designing around the patient. I might give it a 3 or a 4 if you put in the countervailing force of healthcare workers who come into the field because they have a powerful need to care for patients. So despite the fact that all the system structures and processes designed not with the patient in mind, wonderful, caring, loving nurses and doctors and other medical health professionals, non-medical health professionals, really powerfully care for patients. So we do end up getting maybe a 3 on the efforts of individuals, but we're not designing behind them. We're more focused on bureaucratic structures like district health councils or LHINs, but we've not focused on the patient.
Natalie.
I agree. I mean, I think if you are a person who has cancer in Ontario, you might have fantastic experiences with a huge team of people looking after you and moving you from town to town and following up on you and so on. But I think for many patients, there is no seamlessness in the health system, and there definitely is problems in having either information that people need to make decisions about their health care, following through, navigating through the health system, having access to making change in policy or even a place to make a complaint where it might actually mean something in the health system. So yeah, I think that there are definite problems. I think though that many policy elites like us around this table, use patient-centered care to win health change that has nothing to do with patients whatsoever.
This question of patient-centered care, and I've left you purposefully for the end here because you're the guy representing patients directly. Where did this idea of patient-centered care originate in the first place?
Oh, it came from the airlines. It was done in Britain. When British Airways wanted to reorient themselves, what they did was they wanted to not be pilot-focused, because that's how the airline was before, and everybody was tried to make sure that the pilots would do well, and didn't really think about passengers. And so they talked about passenger-centered care. Customer-focused care became the term from that, and then they brought it to healthcare. And it was used about 25 years ago to talk about patient-centered care. And the idea at the time was that there were too many people seeing the patients. So they wanted to cut down on the number of people, thereby having fewer contacts with them, and also saving money. So saving money was one of the features of early patient-centered care. In the last few years, there has been a new movement to patient-centered care. Everybody recognizes that somehow we've lost sight of the patient. And so the way in our first public meeting of the Patients Association was when the Canadian Institute for Health Research had a conference that was called Patient-Centered Primary Care. And I looked through and I'm a policy person and a healthcare person, so I looked through the agenda, and there were no patients represented at this thing.
What did you think of that?
So what we did was we created a panel and took some time that one of the other organizations gave us. And we had a panel with everybody saying, well, what we really need is some kind of organized patient voice that could speak to these issues.
Sholem says that the healthcare system, Eleanor, lost sight of the patient, which suggests that the patient was in their sights at some time in the past, and then something went awry. Is that the case?
There has been tremendous change from the time of the development of Medicare, when most of the tools that health providers had, doctors and nurses and others, were in a little black bag. Today, when you look at all the technology that's available, the knowledge that you need, one of the issues and problems that we have is that we're not measuring. We don't know whether we're doing anything that's of value or not. We don't like to be compared. We have a blame and shame environment.
What does that mean?
That means the minister gets off with his or her head if there's a problem out there. I mean, it happened to me. It's happened to every health minister. And frankly, all the government does is pay. And then they trust the providers and the hospitals and the boards that are governing the non-system to see that things are going well. When now, today, and this is where you said we lost sight, the evidence today of the amount of harm that is being done, of the number of people that are dying because of inappropriate care, of drug interactions, this is a wake-up call that says we have to focus on what's happening to people and those patients.
Dr. Doig.
So there are a couple of things that Eleanor said that are really important, Steve. I mean, first of all, the pace of change, the amount of change that we've all seen, the number of innovations that have happened in healthcare, both in the diagnostic side and in the treatment side, even in the 35 years that I've been a doctor, is just absolutely astronomical. So keeping pace with that change, from a payer's standpoint and from a system standpoint, trying to fund that, trying to find effective ways to deliver that kind of care is extremely complex. And that's one of the reasons why care has become siloed. We have to remember that when Medicare came into effect, over 50%, something like 57% of all the service that was given was covered by doctors and hospitals. Right. Now it's down to something like 42, 43%. So there's a lot of things happening that aren't within what we traditionally view as our Medicare system. The other thing is the tools to do the job properly and the ways to monitor. So Eleanor referenced harm and harm reduction. Things like the Quality Council, Saskatchewan being a leader in the Quality Councils, and as you all know, I'm a Saskatchewan doc, I'm not an Ontario doc.
That's right.
But things like the work being done by our Quality Councils and tools for doctors like informatics that are properly used are what we need. And decision support tools, which can be done through informatics.
Ted, help us with this, because you've been watching this healthcare system here in Ontario for a few decades anyway. Everybody assumes, I think people assume, that the system has to be designed around the patient because the patient is the person on the outside who accesses the system. So if it's not designed around the patient, who's it designed around?
I hate to say this, it's designed around the convenience of the providers. I remember the very first speech I had to write. I was working for the Bill Davis government. and I had to write a speech for the Honorable Dennis Timbrell, the Minister of Health. First speech, I didn't know anything about healthcare. He was going to go and speak to a group of architects who designed hospitals. And I didn't know what the heck to write, but I talked to a friend of mine who was in a hospital and discovered that in their hospital room, the lighting was set for, like this studio, for being able to examine sutures. When we asked the nurse, can you turn down the light, there was no dimmer switch or anything else like that. I think today that's changed, but it kind of gives you from 30 years ago to today, we are still designing around the convenience of providers, not around the patient. And of course, healthcare has become very dangerous, Steve. Eleanor referred to harm, you referred to harm. We're talking about 1 in every 13 people that walk into a hospital are going to be harmed. So these are very dangerous places.
1 out of 13 people will walk into a hospital and have something negative happen that they were not in there for.
Preventable accidents. We kill about 25,000 people a year by accident in our hospitals in Canada. Preventable deaths. And so people need to be very alert that the patient-centered care movement is a lot about the quality movement. It's a lot about focusing around the needs of the patient, focusing around quality, focusing around safety, and really fundamentally tackling many of the problems that we now face in our system today.
Are you convinced that if we had a more patient-centered system, this kind of thing would not be happening?
Depends what you mean by patient-centered. I mean, the thing that's so interesting about it is that I think that everybody who goes into healthcare goes into it because they want to make people better.
I agree.
I think that everybody goes in with absolute, they're altruistic, and the altruism is spread throughout the system. The thing that's really interesting. I've worked at Bakewrest for a long time, and what you discover is that what each of the different professional groups thinks is different. And they all have different things that are going to be for the good of the patient. So you have all these altruistic people trying to do what they think is best, and very often the patient isn't at the table.
So who decides?
Well, I think that they decide among themselves is what happens, because there hasn't been a strong enough patient voice, and there hasn't been a patient at the table to say what things look like from the patient perspective. And a lot of the things, like the thing that Ted is talking about, is about sort of going into a room and discovering that the room is set up not to let you sleep, for example, is part of that. It's sort of not looking at it from that perspective, and getting a voice for that perspective is very hard, and has been very hard.
Eleanor and then Ann.
The other part of this is that every incentive that we have in place right now, every payment incentive, every building incentive, is perverse.
How so?
It's the wrong incentive to the outcome you want. Well, for example, we pay for quantity, we don't pay for quality. So in the fee-for-service system, the more people you see, the more pay you get. The fewer people you see and provide greater quality, spend more time, listen to the patient, make them a member of the team, the less you earn, which is why alternate payment and alternate finances and funding mechanisms that were started 20 years ago. We have one at Queen's, we have one at Sick Kids Hospital. The Ontario Medical Association has been very reluctant to see a shift from fee-for-service to a way to pay physicians, particularly.
Is that because they make less money?
Not necessarily. It's because fee-for-service has been fundamental to the freedom of how doctors would practice. Similarly, they're against any kind of performance review. No performance is acceptable. A doctor is permitted to do whatever they want to do unless the patient complains.
Okay, Ann, your turn.
Well, I can't necessarily argue for or against what Eleanor quotes the Ontario Medical Association is saying, because I'm not a member of that association. I don't speak for it. What the Canadian Medical Association has said is, in fact, that we need to reward quality. We need to reward people for performing well, whatever that means.
So docs would be open to being taken off fee-for-service?
If you can provide us with enough docs to do the work, and this is the other point that lies behind arguments about payment and all these other things. Payment and service are inextricably intertwined with each other. I've spoken to lots of ministers of health and lots of deputy ministers of health who all say privately, hey, listen, fee-for-service is the cheapest thing going. So we know that, in fact, if they tried to provide the physicians and other health personnel, physician extenders, all those other kinds of people, to do the work that needs to be done and give us the time to take to be with our patients and pay us to be there 24/7. A lot of us are there 24/7. But have payment models that reflect the true activity that is expected and the volume of work that needs to be done, we need far more providers, and yes, it's going to cost more.
Ted.
There's a perverse economic incentive on the fee-for-service basis
What is
because,
it?
well, you got to move your patients through as quickly as possible. So a recent book by Jerome Groopman called How Doctors Think uncovered the evidence that if we get doctors to listen for another 90 seconds more of listening to their patient, they would correct diagnosis by up to 50%. So misdiagnosis in people in hospitals and the complications that result as a consequence can lead to death and errors.
Hang on a second. Does that make sense to you? 90 seconds more of listening could reduce misdiagnosis by 50%.
I actually teach communication skills to first and second year medical students, and one of the messages we give them consistently is to become tolerant of silence. Let the patient have the time to tell their story. Whether or not it's going to result in the statistic that Ted has just quoted, I honestly can't answer.
But 90 seconds more for each patient presumably means you're seeing fewer patients at the end of the day and not being remunerated as well. So it's
cost to the system is much less because the complications caused by misdiagnosis is a serious problem and very expensive.
Problem for the doctor's pocketbook, though.
But
yes.
I don't think that that's true. I think that doctors' pocketbooks aren't harmed by these things. And in fact, I think that a lot of it is practice and history and how people are trained. And I think that what's happening among doctors, as well as among everybody else, is a very strong feeling that things have to change. So to give you an example of that, tomorrow I'm going to be giving out the first Patient's Choice Award ever to two doctors in Peterborough. And it's sponsored by the Ontario Medical Association because they recognize that it's really important to reward and to recognize doctors who are especially patient sensitive.
What did they do to get this award?
What we had them do is we had people in Peterborough nominate doctors to tell stories about what the doctor has done for them. And what they've done is to stay with the patient, to form relationships with them, to listen to them very carefully.
Yes.
And the three words that came out in most of the nominations were listening, hearing, caring. And that's what's on the award. Those are the three main characteristics that people really appreciate in their doctors.
Whenever Ann is on this show, we have to quote somebody from Saskatchewan. So we're going to do that right now, Ann. Saskatchewan studied the patients. Let's bring this graphic up. This is the patient first review that was done in October 2009. And here's the quote from it. Patients ask that healthcare workers and their respective leadership see beyond their declared interests so that the interest of patients takes precedence at every care interaction, every future contract negotiation, and every policy debate. Natalie, I want to ask you, do you think the unions in the hospitals, the people who represent the orderlies and the nurses, and the doctors for that matter, do you think they negotiate their contracts in the best interests of the patients?
I think that collective bargaining happens as it does in every sector. That on one side there are people who are looking generally to protect what they have. On the other side, there are people who are looking generally to try and contain costs and gain more control over the workplace. And so I think that that's how it happens. But I think what we're seeing in the health system in terms of change that's moving away from patient-centered care, as everyone was talking about before, is that every policy shift that we've had recently to try and contain costs, to try and change the structures of healthcare, have actually worked to alienate patients more. They've increased administration, as we've seen all across Ontario, and I think that trend is sort of holding true across the country as well. At least that's what we hear from our counterparts across the country. And patients seem to have less and less ability to impact the way that their local health system works and how it works for them.
Let me play devil's advocate here with you for a second, Eleanor, and that is that while a patient goes to a hospital or a doctor's office or whatever to get better, this is also their place of work. And they have workplace rights, and they have things set up in a way that makes sense for them to do the best job they can. So there is a balance of rights that we have to deal with here. Is that not correct?
I think that when you're dealing with healthcare, the goal of Medicare, the goal of healthcare is to have the healthiest population that we can possibly have. I'd like to see Canada have the healthiest population in the world, and I think it could be achievable. The problem is this. There are two things missing from healthcare in every office, in every interaction, and I'm generalizing, but transparency is missing. There's even a debate over who owns the record as to whether the patient has access to their record.
Whether they own it or the doctor owns it.
Yeah, exactly. And there are those of us who feel very strongly, it's me, it's my record, I should not only have access to it, I shouldn't have to pay to get part of the record. And the second one is accountability, both accountability to the organization and accountability to the patients. One of the situations that we have is a schism, a break. The doctors, particularly in Ontario and probably other provinces, have this notion that they're not accountable to the hospital because they have privileges. And the resources in the hospital are allocated to equalize physician income, not to look at what the community needs are. So how can you be putting either individual patient or the community's needs first in your planning if what you're really interested in is equalizing income? And the example of that was when Ontario decided to address wait times. They went out and purchased additional capacity because they could not reallocate from low priority services to high priority services because that had to be negotiated with the doctors' union, the Ontario Medical Association.
Well, let's try this though. Michael, let's put this next graphic up if we can. What doctor shortage is the question we're asking here. 92% of Canadians say they would recommend their physician to someone else. That certainly suggests a level of confidence in their family doc. 85% said they have excellent access to primary health care. That's from the Canadian Institute for Health Information, which is, tasked with collecting this information. Sholem, those numbers don't suggest that patients feel they aren't at the center of what's going on in the healthcare system.
Well, I think that one of the things that's really interesting about healthcare is that most people who have primary care doctors love their doctor. That's just true everywhere. And the relationship between individual patients and primary care doctors is pretty good.
Is that because they're just grateful to have a doc?
A lot of times it's that, and I think that a lot of times it's also the fact that the relationship between people and their primary care doctors tends to be more long-term. It doesn't tend to be as fragmented, and that's becoming more difficult in some cases and easier in others. I think that there's a much more fundamental issue here, which is what the nature of health is. And the way in which our understanding of health has been shifting. And I think that that's been happening in medicine and in other places, is that our hospitals were built as acute care hospitals. And they were built to deal with acute diseases, like infectious diseases, like smallpox and cholera and things like that. Well, but what's happened is that people don't die of those diseases anymore. They die of chronic diseases, of things like heart disease, of cancer, and those kinds of diseases. And our whole system is skewed to deal with acute care. So people don't see people in the chronic phases of their diseases. They see them only in the acute phases of the diseases.
Ted Ball.
The healthcare worker is, in fact, the patient's best friend. I want to give you an example from a case at North York General Hospital here in Toronto, where they got together, they wanted to redesign the processes between the arrival of a patient at the emergency department and getting admitted to a bed. There's 169 steps, okay? Takes hours. So they brought together all the workers with some patients and asked the patients and the workers, we're going to take you through each one of these 169 steps. We're going to ask you, would you pay for this out of your own pocket? And if you won't pay for it out of your own pocket, we're going to get rid of the step, okay? So at the end of this exercise, they went from 169 steps to 10 steps. Huh. They shaved 5 hours off the wait time and saved hundreds of thousands of dollars.
Why are we not doing this everywhere all the time?
Well, that's what we should be doing. If we're going to redesign our healthcare system based on patient-centered care, it's about bringing patients and frontline workers in together to massively redesign systems, structures, and processes to make them more.
Okay, I got some numbers on this then. And Eleanor, this goes back to the conference we attended, because we actually talked about all this at the conference. It was the Ehealth Achieve conference. The Ontario Hospital Association put it on. There was an informal survey done of the audience. They gave the audience clickers and they could vote. 100 people from all walks of healthcare life across the country at this conference. So, no, not scientifically, I guess,
Focus group.
up to the standards of pollsters, but yeah, a focus group. Everyone seemed to agree that Ehealth was a very big deal, getting patients' records computerized so that regardless of where you got sick, if you live in Ontario, you got sick in BC or Saskatchewan, you could get access to your records. Let's put up some of these numbers here. Michael, let's go to the first one here. Question, will your province have Ehealth by the year 2015? What did people say? Only a quarter of those in the room thought yes. 75% thought within 5 years we still won't have Ehealth. Let's do the next one. What has been the biggest obstacle to Ehealth implementation? and they were asked to vote on a series of answers, and 55% said poor planning. What next? Physician engagement, only 18%. Failed implementations, only 14%. But poor planning, more than half the people. Let's do one more here. How would you characterize the approach to eHealth implementation? That was the next one. Let's flip it over, do one more. How would you characterize the approach to eHealth implementation? Too much reliance on top-down, 2/3 of the people said that. Too much bottom-up, only 27%. How many people thought the balance was just about right? Only 7% of the people. Okay, I want to go around the table here and ask everybody to tell us what they think from these numbers. And what do these numbers say to you?
Well, they're absolutely right on. What has gone wrong with the implementation of computerized medical records and eHealth is exactly what was shown on your slides. So we have a top-down system in implementation and in system design. I've had a fully computerized medical office for the last 10 years and counting. I still do not have functional connectivity. I do not have functional interoperability. In other words,
what does all that mean?
Okay, connectivity means the ability to connect one computer to another computer. Interoperability means the ability to do something in this computer that means a change in this computer. I don't have either of those.
Why not?
The one thing I have is I have lab results coming into my file, and I'm one office out of several in the city of Saskatoon. There are, I think, 4 or 5 of us that actually have that much connectivity. We can't operate in an environment where, in effect, my computer medical record is nothing more than an electronic version of the old-fashioned charts that I had locked up in a room in my clinic 10 years ago.
Eleanor, you were Minister of Health, late 1980s. Sudbury's building new hospitals. Tell the story.
Well, Sudbury had 4 hospitals and a population of about 200,000 people. I was the minister. I went to Sudbury and I met with the boards and I said to them, I don't care which system you choose. All I'm asking you is that you choose the same system so that you can have interoperability, so you can talk to each other, so you can share information. I asked the boards of each of the 4 hospitals to do that one thing. What do you think they did?
We're afraid to ask. What do they do?
2 separate systems.
Yep.
And they did it, in my view, because of the interests of the individual hospitals, the providers, and that they didn't want to share. What I find is that we have a culture which is the antithesis to sharing because we're afraid of the comparisons and we're also afraid of exposure because we know that if we have interoperability and connectivity, that somebody will have information that they can use against us. We have to create an environment where we eliminate blame and shame, where we look at these opportunities to improve in a constructive, continuous improvement mode so that the providers don't feel afraid. Very often the frontline are afraid to say, I can give you an idea on how to do it better.
Okay, quick follow-up here. You were the Minister of Health.
Yeah?
You funded those hospitals.
Yes?
Why could you not say to those hospitals, guys, one system, period, full stop?
Because all the minister does is pay. They give them a transfer payment budget, and then each hospital in Ontario is either a private, there are 3 private, or all the rest are not-for-profit private corporations with a board of directors that make the decisions.
So you can't tell them what to do?
Can't tell them what to do.
Sholem.
Well, the idea of interoperability also has to do with interoperability with patients.
Right.
And one of the things that's very hard to get is to get patients into the system in any kind of way. So and in fact, that's not even thought about, which is really interesting. And if people have chronic conditions, then they're the people who have to know what's going on. And so having access to their record and having patients have access to their record should be a very critical thing. It's not even part of the mix. It's
Natalie.
really interesting.
You know, I have 3 examples I think that are useful. 1, Cobourg, Ontario. The local health integration network holds a meeting with 28 individuals to determine the scope of services in the local hospital. They vote on it. The local hospital ends up cutting diabetes education, physiotherapy and occupational therapy, and a whole bunch of hospital beds. The community, up in arms, several protests, 10,000 signatures on petitions opposing this, and yet the Ontario Hospital Association just gave the Cobourg Hospital an award for that being a great consultation model for community consultation and involvement with the LHINs. The Minister of Health just cited that example in a letter to me as a great community consultation on reforming hospitals. Part of what's going on is that they're just completely out of touch with what the public cares about, which is, I want to be able to go to my doctor. I want to know what the tests are when they get back. I don't want to have to phone 15 times. I want to be able to go to my local hospital and get quality health care in my local hospital. Example 2,
Well,
Stratford.
hang on, but just before you go there, you know, I know we're not supposed to say nasty things about the patient here. However, I mean, it's also possible that the public wants absolutely every service they possibly can have free of charge under the roof of the local hospital, which is no more than 5 minutes drive away from their home, right?
I actually don't think
And
that
what?
that's
And is
true.
open
And is
24/7.
staffed 24/7.
Yeah, I don't think that that's true. In fact,
Oh, come on, that's not true?
No, I don't think that's true at all. In fact, Ontarians already have been used to a rationed level of health care. Their local hospitals no longer provide the same scope of services they did 10 years ago, even 15 years ago.
I'm just thinking this
Those-
hospital is
they
not here to
often
defend
drive
itself.
to-
So I don't know what their rationale was, but
Right.
presumably hospitals have to make decisions about what they can and can't do.
Oh, well, I can give you the rationale. They're worried about their budget. I mean, every hospital has to tighten their budget, and there are certain services that they're being allowed to cut, like physiotherapy, outpatient physiotherapy across the board, and that's what they're doing. The fact that it doesn't make sense to increase the number of hip and knee surgeries you do while you're cutting outpatient physiotherapy doesn't, seem to play in that.
Okay, Ted and then Ann.
The failure of e-health has been used as an excuse for a decade for why we're not progressing, and there's no question that e-health can bring real benefits. However, the collective intelligence of frontline workers, in the case I just gave you, Shalom and I have done something called open space conferences in healthcare in a number of places, mobilizing collective intelligence, showing us where we can make real improvements to the system. And so I really think that the excuse of not doing well on e-health is it's no longer a valid reason for not making improvements in healthcare.
And then Eleanor.
So I want to come back to something that Eleanor said a while ago, and that was the question of the blame and shame way of approaching quality management. There is absolutely no question that physicians are willing and ready to have people compare quality, and I think all health professionals are. The problem partially has been that we can't get good data. And there's no question that allowing us to have interoperable systems where data can be shared will absolutely improve quality of care and reduce the number of incidents of harm. Talk about drug interactions as just one very good example of that. There's no question that if there were incentives, and we talked about perverse incentives, everybody gets paid the same for a service. And I don't care whether we're talking about the people who clean the floors or we're talking about the doctors who do the surgery. Everyone gets their pay, whether it's fee-for-service or it's a contractual negotiation. They get paid regardless of the quality of the job they do.
No recognition of merit or experience.
If we
or that
do
kind of
merit,
thing.
and however you define merit by quality, you define merit by patient satisfaction scores. If there's a blend of that kind of thing coming into the equation somewhere, we start to see shifts in attitudes and shifts in performance.
Eleanor, then Shalom.
We have been unable to get any kind of common definition, common language, common coding that would allow for the kind of information. And because we have lots of data, we're drowning in data. We just don't have good information, and we don't have good information because we can't get anybody to agree on what the definitions should be. And we can't get them to agree, to give up some of their turf. There's so many of those turf issues that are out there. Let me give you a couple of statistics, and that is, today everybody's talking about the interprofessional team model. Interprofessional care, all the literature says, improves the results for the patient.
And that basically means what?
What that means is the doctor, the nurse, the nutritionist, the dietitian, especially when you're talking about chronic disease management, most of which can be provided in the community. What people don't understand is the worst place to go for services is in the hospitals where you have the highest infection rates. That if you have a service that can be provided in a community clinic that is connected to the hospital, and I did the study on home care, rehab services can be provided at home. I had 2 knee replacements. I was the shortest length
You
of
personally
stay.
did?
I personally, Shortest length of stay for 2 knees. I was out in 6 days, and I had all of my rehab done at home by home care. And I had a fabulous outcome. The hospital stay, the patient experience, certainly was one that could have been improved, and I gave them my input. I'm not sure they were thrilled to have it. But in fact, we need that patient voice. We need people to understand where they're going to get quality and why it's important not to provide some services inside the hospital. Why ambulatory outpatient, that means where you don't have to stay overnight, can and should be provided in a safer environment than the hospital. And that's hard for hospital workers to accept.
Sheldon.
That also has a lot to do with money.
Yep.
So, for example, the UK spends much less on healthcare than we do per capita. And the quality of care is not significantly different. Big difference, a huge difference between the UK and here is the amount of money that they spend on community care in the community, and care at primary and levels outside the hospital.
They do more?
They do more. So they do a lot. They do things like fixing up your house so that you don't fall, right? They do things like every child in the UK is visited by a health visitor just after it's born, even the Queen's children. As a requirement. So this kind of stuff it's a completely different balance. People in the UK think there's not enough of it.
So I guess the idea is it's easier to fix a broken leg if you don't break your leg in the first place.
That's right. And the notion and how chronic conditions are treated best is treating them outside the hospital. And the shift here is away from Canada is a very institutional country. And our organization towards institutions and towards hospitals is very, very long-standing. We have more hospital beds than we need. We probably have far more long-term care beds than we need if we provided more care outside those institutions.
Dr. Doig.
So Dr. Turnbull, who's the current president of the CMA, will tell you that every day he goes around the hospitals for which he is responsible and tries to find places to put the roughly 160, 170 people who really don't need to be there, whose level of care is such that they would be better looked after outside of the acute care hospital setting. We don't have the infrastructure, either in terms of bricks and mortar or in terms of healthcare professionals who can do that work in the community.
Can you tell me something? Why? I mean, I've been hearing, for 25 years I've been hearing people say what you're saying, and yet it's still not there. Why is it still not there?
Part of it is because there is such a huge demand for the high-tech services that need to be provided, and I mean, we all need them. If you're the person who needs to have an arterial bypass graft for your heart attack, you don't want to hear that 3 people out in the community needed to have home care services. You need to have your surgery. So somehow we have to find that balance between the high-tech environment, the in-hospital care, and the external care environment.
Natalie.
Yeah, I was going to say that everyone theorizes that people could be taken care of outside of their hospitals as they cut services in hospitals, but those services don't tend to materialize, or if they do, they materialize much more slowly than the cuts do. And so patients do fall through the cracks, and I think we're seeing that in a significant way. What we see is that the kind of fragmentation and not responsiveness of the system is not alone the fault of hospitals. I mean, if you look at home care in Ontario, it's fragmented. Care is cut into hour chunks that has nothing to do with the holistic needs of the patients. There are 10 providers in each community. All of them have different computer systems. They don't talk to each other. They compete with each other, actually, in a kind of competitive bidding system that actually sets up boundaries so that they will not share information with each other.
We're going to get into an argument here about whether competition in the healthcare system is a good thing or a bad thing?
Well, it's the same culture that you were talking about earlier. If you have an interest, if you have a financial interest in not sharing information with your competitors, that surely is going to affect whether or not you have an integrated healthcare system. If you have a monopoly
on providing services, presumably you got nobody nipping at your heels to be better also.
Well, except unless you unleash the patient's voice, unless you actually bring in some democracy, unless you allow the frontline workers and the patients to actually say the problems that they see and bring in some change.
Ted and Sheldon are nodding their heads over. How come you're nodding? You're going like this.
Well, I'm going like that because it seems to me that the question is, where is competition? working for high quality, if you have altruistic people working for high quality and working together to do it, then competition isn't appropriate. Collaboration is more appropriate. And then the question is, when Tony Blair was elected to office in the UK, the word went from Thatcher's competition to Blair's collaboration, right? So the language, it's a kind of political language. I think neither of them is the way to think about it. You have to think about that one of the things that people are trained to do in healthcare is to provide the best possible care all the time. So they're going for excellence, and figuring out how to do that and figuring out what kind of system you need in order to do that is part of what you have to do.
Ted, then Eleanor.
Steve, incentives drive the system. So we need a whole new set of incentives here. If hospitals were rewarded on the basis of high patient satisfaction rates and high quality.
Rewarded how?
Financially.
Give them more money.
Give them more. If you have lousy patient satisfaction and poor quality, and you lost several millions of dollars, and it moved down the street to another place that was providing good quality, so now we've got competition based on something that's really important to patients. So,
Pity the patient that lives in the hospital that loses funding because it's got poor quality.
You either use economic incentives to drive an agenda for patients, or you're left in the circumstances that we're in.
Eleanor.
I think it's really important to understand that when you're looking at system development, it's how everybody works together, how they collaborate, what the incentives are, and how you reward performance. If the only competition that we have is to compete for the best quality and the safest environment on the basis of outcomes and results, I think we would have 25 to 30% of the dollars available to reallocate to those things that would really matter in the community. I think while we have such duplication, we have no incentive for efficiency, we don't reward performance, and any suggestion that you're shifting or moving anything is seen as a cut. When I was Minister of Health, we were increasing the health budget in double digits every year. The hospitals would submit a budget that was like 20% increase. We would give them a 12 or 13% increase, and they would scream that their budgets had been cut. That's the game.
And my guess is when you're having a press conference and there's a white lab coat and they're believing the white lab coat.
Of course, because the language that we have gotten used to is you can't believe government. The providers care about you. Government only cares about money or spending taxes or cutting. The reality is the government wants value for the individual who is receiving care. Government also wants to make sure that we provide prevention so we can have a healthy population. All of the money can go into our health system sector or health non-system, and we will rob education and all of those other areas that we fundamentally need to have a good economy.
I want to give Natalie a chance to make the point that she was just about to make along the lines of, if you reward those who are doing the best, what do you do about the hospitals and the patients in those hospitals where they're not running things as well?
For sure. I mean, we don't have a system in Ontario or in Canada where there are many hospitals in the same town doing the same things. So if Hospital A was to lose its funding because it had poor outcomes or because it didn't deliver enough cataract surgeries or whatever the incentive is that they're supposed to be funded based on, what happens to the patients in that area? It's, in many places, it's another hour or two drive, at least in Southern Ontario, to the next 100,000 person town where you might have a secondary kind of hospital. This isn't a market in which patients can just willy-nilly travel around the province or the country accessing healthcare. That isn't how it happens.
Eleanor wants back at
I
you.
think we need to give people the information on where they're going to get excellent care, where they're going to get okay care, and where they're going to get poor to mediocre care. And if we give them that information and we say to them, are you willing to drive or travel 25 minutes or even an hour to get excellent care as opposed to mediocre or poor care, giving them that information, I think, is extremely important to watching system development.
Are we doing that today?
No.
We're not giving them that information?
No.
But
Natalie.
we are actually. I mean, part of what happened under this government is that they have created a website for wait times, and people can go on, although precious few people. I mean, I travel all the time. Almost nobody has heard of this website. And there'll be hospitals, like, I won't give the actual hospital, but in southwestern Ontario, a hospital that has almost no wait times for hip and knee surgeries and is expecting to fill its roster of hip and knee surgeries from patients from Thunder Bay. Well, that's nonsense. I mean, to get from Thunder Bay to the middle of southwestern Ontario is virtually impossible. We don't live in a healthcare market. Patients really need a system in which they have accessible care, and geography matters in that there's as much of a continuum as we can provide within their local communities, quality care. I think the way you assure quality is you set strong standards, you enforce those standards, you take off all the gag orders for the healthcare workers at every level, the professionals right through to the cleaners. You take those off and you allow some democracy within our healthcare institutions. You give patients a real venue to complain to actually raise their issues, and it can't just be the ombudsman, but that would be a good start.
Sure.
And you actually engage them in policy change.
Mm-hmm.
Well, one of the things that was true in the UK was that what Eleanor said turns out not to be true. It's that people go to the closest hospital, by and large. So they had all that data. The data was out.
Even if they know there's a better one.
Even if they know there's
away.
a better one. Even if it's an hour away, one of the consequences of an hour away means that people have to travel an hour away to visit. So there's a cost. A friend of mine who's a cancer doctor says that in Canada, parents can afford to have one child who has cancer, but can't afford to have two. You go bankrupt. And you go bankrupt not because the care isn't delivered, you go bankrupt because you have to be there. And so a lot of these things don't have a lot to do with geography. So providing good quality care in geographic and all over the geography is a real issue.
That's the goal.
Ted.
What we need is more accountability. It's not acceptable that we've got boards out there who represent, and boards, by the way, under the new legislation are, in the olden days, boards were there to represent the interests of the organization. Today, boards are supposed to be there to represent the interests of the owners of that facility. So if we're going to have patient-centered care and reward quality and reward high customer satisfaction, high patient satisfaction, high family satisfaction, then boards of organizations need to hold their CEOs accountable for achieving those outcomes. And if they fail to do that, then there's got to be consequences to that.
Some hospital CEOs in this province, not a lot, but some are making $400,000, $500,000, $600,000, $800,000 a year. Can you keep people who are making that much money accountable in the way he described?
You have to. And not only that, you have to make sure that they work closely with the physicians so that you don't have a silo of doctors and a silo of administration. What you need to create is a team within the organization that work together for the purpose of the best patient outcomes. And what you need, I use the term critical mass, you need enough volume to prove that you're providing quality of care. The CEO has to be accountable, and the chief of medical staff and all of the doctors have to be able to work for that same goal together. I think they'd like to. I think we have a culture out there that does not encourage that.
And Doig.
I think we have a culture out there that does encourage it. We just haven't been let to. There was a very strong movement in the 1990s that said, you know what, it's all the doc's fault. Keep them away from the table, keep them out of the picture, and we can fix it. We can fix it if we don't let them to the table. Folks, you can't fix healthcare if you don't have the docs at the table.
Because you're the gatekeepers.
Well, no, not because we're the gatekeepers.
Well, you are, though.
But because we are the people who fundamentally are trained in diagnosis and fundamentally trained in determining the treatment pathway. Acting on it then becomes all kinds of people, and it's always patient-centric when it's in an individual patient decision.
I got a few minutes left
we
here.
need accountability.
You also have to have the doctors, the providers at the table when you are designing the computer systems.
Absolutely.
Or they won't be able to use it, and they won't use it. And the patients as
too.
well. Yes.
Okay, I got a few minutes left here. Let's do one more graphic from this OHA convention. And that was, if I had $1 billion, here we go. If you had $1 billion new dollars to invest in healthcare, where would you put it? And the 100+ people in that room said hospital system process redesign, which does not sound sexy, does not sound like pay doctors more, buy new MRIs, give me services in my hospital that I don't now have. They're talking about process redesign. How about long-term care and home care? 20%. Health IT implementation, 18%. Ted, why would this get, be number one with a bullet?
Well, I'm stunned. I'm delighted because I think they're right.
What does it mean?
Well, Shalom said the answer to the question of where did patient-centered care start, he said the airline industry.
Right.
Take you to another bizarre one, which is Disney Corporation. The Disney Corporation is expert. Anybody who's been to the Disney theme parks know that customer-focused care is absolutely incredible. So redesigning our system structures and processes with a view to treating people like customers, that in a service industry, extremely sensitive to the fact that these are highly emotional circumstances that patients are going through, dealing with the fact that they've got anxieties, they've got fears that have to be dealt with. So you're designing a holistic approach, using the collective intelligence of frontline workers, bringing in, and patients, and absolutely bringing in patients, and listening deeply to their concerns. You can design, and what we know about this, the good news is, this massive redesign has demonstrated time and again to be vastly less expensive, usually about 30% less expensive than is the current circumstance.
As long as you can implement it.
Yeah.
You've never been successful at implementing. They do a
Oh, yes, we
great
have.
job at planning. In Saskatchewan, you have.
Oh, yes, we
In
have.
Saskatchewan. If you had $1 billion, is that what you'd do with it?
Well, if I had $1 billion, I would figure out ways of building up all the ways of dealing with people with chronic conditions outside the hospital. I mean,
I
that's
think
what the
that was
money
one
would
of the
go to.
choices they gave.
No, but they don't. But I think that there has to be a much deeper re-understanding of where we are. Like, the part of the problem about electronic records is that the records don't count the longitudinal issues about chronic care. It doesn't allow for understanding how much exercise you do. That's not one of the data points. It doesn't allow you to understand, because all it looks at is acute episodes or the metrics of instrumental medicine.
Eleanor,
That's not enough.
Do we need massive system redesign?
Yeah, well, we actually create a system. We don't have a system. So if you're going to break down the silos and create a system, that's redesign. And that's transformation. But I think you have to start with the right values, which is what's the outcome you want. You want a healthy population. You want people to receive high quality care. And just as you get on the airplane, when Air Canada and others say your safety is our #1 priority, I'd like to walk into every hospital and hear that over the speaker system, not only for patients, but for visitors and for staff.
Instead of signs that say abuse will not be tolerated.
Absolutely right.
Can't stand it.
Where do you see that?
Yes,
Hospitals,
In hospital?
you bet.
Abuse?
Doctors' offices, abuse will not be tolerated.
Oh, I see.
If we were focused on patient care,
That's right.
and this is something I've told my staff, if anybody puts a sign up like that, well, they won't dare because I've threatened to fire them. But seriously, if we are focused on patient care, we don't need signs that say abuse will not be tolerated, because we will be respectful of the anxieties and the concerns that cause people to get irritable.
Well, I can tell you one thing. We've put the patient first here on TVO for the last hour, and I'm grateful to all 5 of you for coming in today to talk about it. Eleanor Kaplan, the former Ontario Health Minister, Ted Ball, the Health Policy Analyst, Sholem Globerman, the Patients Association of Canada. On the other side of the table, Dr. Ann Doig from the Canadian Medical Association, Natalie Mehra from the Ontario Health Coalition. Thanks so much, everybody. Still a 1 out of 10, eh? Still a 1.
Well, I think we could get there if we did
But
some of the
getting
things we talked about.
trending better, trending better.